everyone. We are almost welcome to this session, and today it is our first lecture in maternal newborn nursing 2. My name is Gladys from Uganda, and I'm a midwife. I want to say Happy New Year to everyone, and I want us to start with the objectives. And the topic of today is antepartum hemorrhage. So our learning objectives for today is to define antepartum hemorrhage, define placenta previa and abruptio placenta, identify the risk factors and signs of these conditions, then explain the diagnosis and management of these conditions, and lastly, we have to discuss the implications for maternal and fetal outcomes. So in the definition of antepartum hemorrhage, I want to say that antepartum hemorrhage is bleeding from the genital tract after 26 weeks of gestation and before onset of labor and delivery. As the word says, antepartum is before. So I usually used to say that antepartum hemorrhage is from 26 weeks of gestation. But right now, according to the reviewed guidelines in maternal newborn health, we are considering after 26 weeks of gestation. And the reason is because we have the technology, we have developed our skills on how to manage preterm babies. And for that case, the cutoff point for antepartum hemorrhage is at 26 weeks of gestation. So the causes of antepartum hemorrhage are abruptio placenta, placenta previa, and ruptured uterus. So in the following slides, we are going to explain in details the meaning of these terms as the causes of antepartum hemorrhage. We are going to understand what abruptio placenta is, what placenta previa is, and what the ruptured uterus is all about. So there are also other causes besides the three that we have already mentioned, and that is vaso previa, and then bleeding from the lower genital lesions. That is due to cervical ectropion, cervical polyps, vaginal varices, and cervical cancers. Placenta previa and abruptio placentae are the major causes of antepartum hemorrhage, and I want us to understand what placenta previa is, what happens in placenta previa, and what could be the causes of placenta previa. So placenta previa is a condition that is characterized by bleeding from a partially separated placenta that is locally located wholly or partially in the lower uterine segment, or it refers to also painless vaginal bleeding due to low-lying placenta after 26 weeks of gestation or before delivery of the baby. So the placenta is located at the lower segment of the uterus, and when time comes when there is dilatation of the cervix, it can cause wearing or separation of the placenta, and this can cause the bleeding before the baby is born. So placenta previa and abruptio are the major causes having mentioned. So I want us to see where the placenta previa can occur and where is the placenta located in the case of placenta previa. So where you see my cursor, this uterus, the baby is lying well. This is a normal lie. And this red part here is the placenta as it's being labeled. And then we see the umbilical cord, which is this part where the cursor is running through. And this is our baby. And then the uterine walls are all around the baby, as you're seeing the labeling here as the uterine wall. Then you have the cervix just below down here. But in this one, this is the normal location of the placenta, and the placenta is here at the fundus, that is on the upper segment of the uterus. Then when you look at on this other side where they are put placenta previa, as having mentioned that placenta previa is when the placenta is located at the lower segment of the uterus, then you are able to see that down here on this uterus is where there is the placenta, and it is down here lying on top of the cervix. So it is covering the cervix, and the baby's head is actually above it. Then you can see the baby is here lying comfortably on top of the placenta. So as it is covering the cervix, when it separates during the time of labor, when there is dilatation of the cervix, then it will cause bleeding, and here we shall call this as placenta previa. So placenta previa, the incidence varies between 1 in 200 to 1 in 300 deliveries. So it's not a very common condition, but when it occurs, it can cost the life of the baby and the mother. Then the risk of reoccurrence is also in the next pregnancies is about 5%. So when someone has already had a history of placenta previa in the previous pregnancies, then you can also start actually putting this mother as one of the risk mothers to again have placenta previa case. So it occurs in about 5% of the mothers who have ever had placenta previa. The types of placenta previa, we need to know the types, and when you know the types, understand the types, then you can also be able to see how to manage. You can be able to know how to handle this mother to have a normal or a cesarean section kind of delivery. So the different types of or the degree of placenta previa is always to help guide us in the management of these mothers when they come in labor. So this one is a normally located placenta. So the placenta is here at the fundus, and the baby is lying longitudinally, and it has a cephalic presentation, meaning the head is down at the lower part of the segment of the uterus. So this one is a normal placenta that is located at the fundus. When you come to the second picture here, you saw this is low implantation of the placenta. So the placenta is located at the lower segment of the uterus, but is not at the cervical or the cervix. It is not covering the cervix, but is just at the lower part of the uterus. So it is just at the edge of the cervix, but it has not reached to the cervix. So this is what is called the low-lying placenta. So it is lowerly implanted at the lower segment of the uterus. Then when you move to the next one, we also see that this baby is not lying normally. The lie of this baby, it is longitudinal, but the presentation is not a normal presentation. It is presenting with the buttocks, and this one is called a breech presentation because the head is up and the buttocks are down, and also the placenta is down. You can look at this diagram below here where the baby has put its back and the buttocks is the placenta. So the placenta is just at the lower segment of the uterus and is partially closing the cervix. So this one can be more dangerous than the first part of the low-lying implantation. So you have to look at this critically and see how you are going to handle this mother when she comes into labor. And we have also to know, because when you look at this grade 2 kind of placenta previa, it has also two different types within the grade 2 placenta previa. Then this other one, the last diagram, you basically look at it very critically and you realize that the placenta has covered totally the cervix and the baby is lying on top of it. And this one is very dangerous. We don't even risk this mother to labor because she can easily bleed and there is nowhere the baby is going to pass because it has obstructed completely the cervix. When it tries to dilate, it will bleed profusely and we can easily lose this mother together with the baby. And besides that, we shall also not be able to deliver this baby because it has obstructed the way or the passage for this baby. So this one is called total placenta previa because it has covered the entire cervix. So I've already explained these different types. The type 1 is the normal one, which is low-lying. The type 2, partially situated in the lower uterine segment. It is at the lower margin, which reaches at the edge of the internal os. So it is also called marginal placenta previa. Type 3, type 3 covers the internal os when it is closed up to 3 to 4 centimeters dilated. So it is partial or incomplete placenta previa. Then type 4 is called complete placenta previa, and this one is the most serious type of placenta previa. So in this type, the placenta completely covers the internal os, even when the cervix is fully dilated. So this is the most severe form of placenta previa. So we can only discover this when we do different investigations, as we shall look at them below as we continue with our discussion. So on this other slide, we are going to talk about the risk factors for placenta previa. So one of the risk factors for placenta previa is more common in women who are aged 35 and above. So the women who are aged this age of 35 and above are at a high risk of having placenta previa, because they might be having also so many conditions that could have affected the uterus. They might be having so many deliveries which could have caused the scars in the uterus, making the placenta to look for a fertile place, making the placenta to look for an area that has never been implanted with the placenta, so that they can be able to get enough nutrients. So in that way, it can end up locating itself at the lower segment of the uterus. So increasing parity and multiple gestation is one of the risk factors for placenta previa. Then uterine scarring, as I already explained, due to prior either cesarean section and curettage. So the procedure of doing curette or curettaging the mother during the process of either removing the remaining products of conception in abortion can also lead to placenta previa, because the placenta will have to look for an area where it can be able to implant itself, not in an area which has a scar. So infertility treatments can also cause this. Then prior placenta previa, having mentioned in the previous slides that the reoccurrence of placenta previa is about 5%. So these mothers can easily get again placenta previa. So the prior placenta previa history can also predispose this mother to another placenta previa. Then smoking, cigarettes, we very well know smoking can cause constriction of the blood vessels and can reduce the blood supply to the different areas, and there can make the placenta to look for any other part where it feels suitable for it to implant, and can end up with implanting itself at the lower segment, causing placenta previa. So there are differential diagnosis of placenta previa. Many times a mother can come when she is bleeding. It doesn't mean that is placenta previa. So there are other factors, or there are other conditions that can make these mothers bleed, and we need to actually explore during the time of investigations, during the time of history taking, so that we can be able to rule out some of these differential diagnoses. So one of them is abruptio placentae, and then vasa previa, cervical polyps, and cervical cancers. This can also cause bleeding per vagina when the woman is still pregnant. So that does not mean that this woman is having placenta previa. So you have to rule out in your investigations and in your examinations that you should confirm truly that this mother has placenta previa, so that you can be able to manage her adequately. So some of the signs and symptoms of placenta previa, for you to rule out that this mother has placenta previa, there are certain signs and symptoms that we really need to look at and consider. One of them is painless vaginal bleeding, typically starting at rest or during sleep. So these mothers can just wake up in the night and they find they're in blood, and they don't know the cause. Sometimes they just realize the bed is wet. So this can be one of the signs of placenta previa. Then usually begins around the 32 weeks, 32 weeks years of gestation, due to Braxton Hicks contractions. And Braxton Hicks contractions are basically contractions that come in a time when the uterus is preparing for labor. So it is just like exercising how to contract, or how the contractions will be during the time of labor. So that one also can predispose these mothers to bleeding, and it can cause a kind of alarm, whereby we may need to know why is this mother bleeding, and you may realize it is placenta previa. Then fetal head remains high, and we looked at one of the diagrams where the baby was lying on top of the placenta and was above the pelvis. So this can lead to poor engagement of the presenting part, and the presenting part remains very high, and this mother may not be able to deliver normally because she has kept this head high. It will not descend, and she has covered the lower segment of the uterus. And also it can cause unstable lie, and when you look at the unstable lie, it may end up in a transverse, because it's trying to see which diameter it that can accommodate its length, and this baby can end up with that kind of unstable lie. Then severe bleeding may also result in low blood pressure, high pulse and respiratory rates, and also shock. So we all look at these signs and symptoms as one of the causes of severe bleeding, because if the mother bleeds, it can cause low blood pressure, it can cause a high pulse, and also the respiratory rates can be high because the mother is trying to compensate, trying to grasp some oxygen, because now what is circulating in the circulatory system is very low, because the blood she has lost has gone with the oxygen, and what is there, the little blood she has, is not able to actually provide her enough oxygen. So she tries to breathe very fast so that she can try to compensate the oxygen rates that she's taking in. And also shock can take place or can occur. And when you look at the low blood pressure, the high pulse, the cold clammy skin, and the mother can become restless because of loss of blood. So this can also lead to shock, and the mother can easily die for you if you don't intervene very fast. So what can be the investigations? There are investigations that we need to do besides the signs and symptoms for you to confirm your signs and symptoms and the suspect of placenta previa, if you're suspicious that this is placenta previa, so that you can be able so to rule out the differential diagnosis having mentioned in the previous slides. So you have to do ultrasound scan to localize the placenta and the fetal well-being. So you need to know where is this placenta located, and it can help you in the grading or knowing the different types of the placenta. Is it type 2, type 2, 1 or 2, 2A or 2B? Is it type 3? Is it the complete placenta previa, which is type 4? And you'll be able to manage depending on the different types. And this one you can only get to know about the location of the placenta when you have done the ultrasound scan. And this can also tell you the fetal well-being, whether your baby is okay, how is the fetal heart of the baby, and how is the baby lying, how is the baby presenting, so that you can manage appropriately. Then blood for CBC, HB, platelet count should also be done, because when you do the CBC, you can be able to identify so many things. Even the HB estimation is there. You can know about the platelets. So CBC is very important. Then also do the grouping and cross matching, especially when you're going to do the transfusion. Then you have to cross match your blood so that you know that really you're transfusing the right blood group of the blood to your patient. So blood grouping can be done during antenatal, and is one of the baseline investigations that you are supposed to do as a health worker during the time of antenatal when your mother comes to attend antenatal. So these investigations are very key and very important when you're managing these mothers when they come to you and they are bleeding and you suspect is placenta previa. So we have the general management of placenta previa. How do you manage these mothers when they come generally in our wards, in our different hospitals, in our health centers, in our clinics? So there's a general management of placenta previa. So management in hospital depends on factors such as blood loss. Having mentioned the signs and symptoms, there's blood loss, and then also maternal and fetal conditions. So you need to know, how is your mother? How is she? Is she having low BPs? Are the pulse very high? Is she in shock? Then this can help you in the management. And also the type of facility where you're managing this mother is also very important. Then placental location, when you do the ultrasound scan, you're able to identify and know that this placenta is either located at the edge of the cervix, or it is located covering partially the cervix, or it has covered the cervix completely. So what are your interventions to save the baby and the mother? And also the gestational period is key so that you can avoid delivering this baby before maturity and you end up losing this baby. And also if the baby is a preterm and the condition of the mother is not okay, and also the baby itself, what are you going to do to intervene that you don't lose this baby? So this is very important as we manage these mothers. Then also we need to refer all pregnant women with vaginal bleeding to a hospital or to a CMOC facility. So CMOC is basically the comprehensive emergency obstetric care facilities. If you are in the BMOC facility, BMOC is a basic emergency obstetric care facilities. So being in a CMOC facility means that you are either in a health center you are in the hospital, or you are in a referral hospital, regional referral hospital, or you're in the national hospital. So these facilities, which are called the CMOC, are facilities that are able to provide theater services. They have the doctors, they have the anesthetists. Those are the key people that are supposed to provide those skills in order to save these mothers. We are supposed to have also blood transfusion services in these smoke facilities. So when you're not in the smoke facility and you receive this mother, then you are going to only provide the basic emergency obstetric care, and that's why we call them the BMOC facilities. So these BMOC facilities receive these mothers. So when you receive this mother, just admit the mother if you can admit her, provide the basic care that you can provide for her, and hurry to refer this mother to the CMOC facility. So before you refer the mother, you can give her an intravenous drip. So intravenous drip of saline or Ringer's lactate should be initiated before transferring, and you have to aim to control hemorrhage and conserve the pregnancy up to 38 weeks of gestation, depending on the state of the mother, the state of the baby, the gestational age, and mostly the bleeding, the level of the bleeding, the severity of the bleeding is very key when you're managing these mothers as conservative kind of management. Then also blood tests. We have already mentioned the investigations, and we talked about hemoglobin. Grouping and cross-matching is very key when you receive them in your facility. Avoid abdominal palpation to prevent severe bleeding. So when you palpate this abdomen, you may cause more damage to the placenta, and the mother may continue bleeding profusely. If she came with mild bleeding and you do abdominal palpation vigorously, it can detach this placenta and cause more bleeding, or it will destabilize the baby, the placenta, and cause more harm to both the baby, the mother, and the placenta. Then monitor and save all pads to assess blood loss. It's very important for us to know the blood loss, because it doesn't mean that all mothers will receive have enough blood, or they have an estimated a right estimate of the HB levels. Some of them come when they are actually already anemic, and they lose even very little blood, but they start showing signs of hemodynamically unstable state. So we need to see how much they have lost, and when we get to know how much they have lost, we shall be able also to intervene. So we need to save the pads if we are able to save them, depending on what the mother is using to pad herself. Then provide a high protein diet. This basically is to help in the repairing of the tissues and in the healing process. Then treatment management of placenta previa. I want us to look at this in relation to the gestational age, because management also varies in the gestational age of these mothers. So gestational age of 26 to 37 weeks with no bleeding. How are you going to manage her? She has placenta previa. You have done the ultrasound scan, and after doing the ultrasound scan, you realize that this mother is actually having placenta previa. How are you going to manage her? So the diagnosis is usually made through incidental ultrasound scan, and that's why we encourage our mothers to do ultrasound scan in early pregnancy and also in late pregnancy, so that we can be able to rule out some of these emergency obstetric conditions. So you have to cancel and avoid strenuous activity, including sexual coitus. So you advise the mother, cancel her, tell her the impact, tell her the condition that she has, and also encourage her to avoid some of these strenuous activities so that they can be able to carry the pregnancy up to term. Then give corticosteroids if it is less than 34 weeks of amenorrhea, and the corticosteroid that we always use is dexamethasone. So we give IM, we don't give IV. We all know the effects of dexamethasone when we give it IV. It itches the mother all over the body, and you don't want them to get that kind of irritation, and some of them may react and end up even destabilizing this mother the more. So we have to give IM in case the pregnancy is less than 34 weeks. We give IM dexamethasone 6 milligrams every 12 hours for 24 hours, and that is for 1 day. Then we also have to continue with the routine hematinics, and that is ferrous sulfate to boost the blood levels, the HB estimates of our mothers, so that when they reach that time of delivering, or in case they start bleeding, they actually have at least some amount of blood that is able to boost their survival during that period of time. So if no theater facilities, stroke blood, refer to CMOC facility. So when there is no theater, as I earlier on mentioned, the CMOC facility is a facility that is able to provide us the services of theater and blood transfusion. So when you don't have that, if your facility is a BMOC, meaning you're providing only basic care, then you have to refer her to the CMOC facility. So if the mother is stable and the fetus is alive, then you have to continue conservative management till 37 weeks of gestation, meaning the pregnancy is below 37 weeks. So you have to manage her conservatively until this pregnancy reaches term, and term is 37 weeks of gestation. Below 37 weeks, the baby is not term, that is premature. So we have to look at this critically so that we avoid delivering prematures, and yet we could manage these mothers conservatively till that period these babies are able to be born at a mature state. Then discuss also with the mother and family on birth preparedness and complication readiness. So we all know that this is an obstetric emergency condition that can end up with complications. So when we get this kind of mothers with this kind of complications obstetrically, we have to cancel them, and then we tell them the possible birth preparedness plans and also the possible outcomes so that they can be ready to handle those complications. Then counsel the mother to continue with ANC and report hospital if bleeding starts. This is not the mother who comes to you and you have identified it with ultrasound scan, that is placenta previa, and she is not bleeding. Then she has to continue her antenatal, but you have to make sure that you tell her immediately she sees any bleeding, she rushes to the hospital. So hospitalize if bleeding is revealed. In case she comes back and she tells you that she is bleeding, then better hospitalize or admit this mother so that you can be able to monitor her perfectly in the hospital. Then perform repeat ultrasound scans at 32 and 36 weeks. That's why earlier on said that we have to encourage our mothers to do ultrasound scan in early pregnancy and in late pregnancies. So if they did it at the earliest period of gestation, then we have to tell them also to repeat at around 32 and 36 weeks, because in the early pregnancies this placenta is likely to be at the lower part of the uterus, but as the pregnancy grows it can also move at the upper part of the uterus at the fundus. So we can be able to conclusively say this mother has placenta previa at the age of 32 and 36 weeks of gestation. Then management at gestational age, and that is around 36 weeks. of pregnancy when there is mild bleeding. So when the mother is having mild bleeding, we also manage them in a different way. So when we manage them in a different way, that means the management that we had during the time of when we discovered that she was bleeding, she was not bleeding but was placenta previa, will now change. We shall have to see that we now intervene differently. That's why it is very important for us to actually know whether this mother is bleeding or she is not bleeding, and also to assess the level and the amount of the bleeding so that we can be able to manage them appropriately. So in mild bleeding, placenta previa, this is where there is no decompensation or deranged vital signs or immediate danger to the mother and the fetus. So there will be mild bleeding, but that bleeding may not be presenting with those signs of low blood pressure and then high pulse. The mother will be normal and also the baby will be okay, but the mother will be telling you, I'm seeing some signs of bleeding. And then you discuss with the mother and family on birth preparedness and complication readiness, just as in the other management when there is no bleeding. So you have to admit or refer to a functional CMOC facility till delivery. So you have to admit this mother in case you realize that there is mild bleeding. And then also, if you cannot handle her in the facility where you are, then you refer this mother to the CMOC facility and she stays there until she delivers, depending on the gestational age. And the other thing you should do is to avoid strenuous activity, including sexual coitus that results into orgasm. So you know what happens. There is a lot of pressure that can be exerted onto the uterus in the abdomen and can cause destabilization of the placenta, and the mother can start actually bleeding. So you have to advise them, and that's why it is very important for these mothers to come for antenatal with their partners. And in the same way, you also have to give them corticosteroids if it is less than 34 weeks of amenorrhea, and you give it IM dexamethasone 6 milligrams every 12 hours for 24 hours. Then rhesus negative mothers should receive anti-D immunoglobulin 300 milligrams at 28 weeks, and again at about or during the 34th week. And sometimes if you miss to give them around that period, then you can give them again at 72 hours after delivery. Then you continue with the routine or daily monitoring of fetal well-being, or you give also hematamics. You have to give them so that they can boost the level of blood in their bodies, that is the HB. And if the mother is unstable, if the mother is stable and there is no active bleeding and the fetus is alive, then you continue till 37 weeks of gestation. If minor placenta previa like type 1 and 2A include induced labor, if no contraindications to vaginal delivery, then that is in type 1 and then 2A, then you are good to go to deliver this mother vaginally. But if the mother is having either type 2B, that is when the placenta, that is grade 2 of type 2, because when you look at placenta previa, we said there are basically 4 types. So when you look at type 2 has also 2 different types within the type 2. So we can say grade 2 has 2 different types of placenta previa, where we say it has grade 2 type 1A and grade 2 type 2B. So when you look at this, it actually tells us how these placentas are located. So grade 2 posterior placenta, this one you realize that it's at the lower part of the uterus, and it is basically located at the lower part of, when the baby is coming, it's just down and can easily be damaged by the head of the baby or the descending part. So that one you do not conduct vaginal delivery, because the mother can easily bleed profusely during the descending of this baby and can cause more damage or more negative impact to the mother. Then the type 2B is when the type 2B is when it is actually above, and that one there it can also we can tell the mother actually not to deliver. Type B is the major one, so we tell the mother that she cannot deliver normally with type B, because type B, that one the placenta can easily also separate. So if minor placenta previa like type 1 and 2A induce labor, but if it is type 2B, then there you should not induce labor, because it can cause more problems and damage to the baby, and can make the mother bleed profusely and cause us problems whereby we may not be able to handle this mother. So we have to look at these two different types, and when you look at these two different types, we can be able to assess on how we are going to manage these mothers. So grade 2, 2A is at least much more better for us to do a vaginal delivery compared to grade 2B, which will be more dangerous for us to deliver this mother vaginally. So type 2A, the placenta is actually located, it is located at the posterior part, at the anterior part, where the mother can easily push the baby and cannot tamper with the placenta. But the one which is at the lower part, that one is the one that can cause us problems. But the one that is at the anterior above, that one the baby can easily come out very well, like any other mother who does not have placenta previa. So we have to assess the type of type 2 placenta previa before we start conducting a normal delivery, or before we start saying this mother should be delivered by cesarean section. So if a degree of placenta previa is type 2B, and if major, then deliver by C-section. So type B is very dangerous, and is the one which is posterior, and the baby can easily separate that placenta. Then the one which is type 2A is where it is anterior, and that one the baby can easily escape and she can deliver it normally vaginally. What could be the indications for immediate delivery by C-section? Why should we do immediate C-section during placenta previa? The reasons are active bleeding. If this mother is having active bleeding and she's getting into hemorrhagic shock, then we need to do an emergency cesarean section to save this mother and the baby. Then if the gestational age is equal to 37 or is more than 37 weeks with mild bleeding, then also we can deliver, because it gives us an indication that this baby is actually term. So delivery can be done immediately, because we do not want this mother to bleed profusely, leading to hemorrhagic shock. Then if there is an evidence of IUGR, IUGR is intrauterine growth restriction, where the baby is actually not growing well. When this baby is delivered, the baby can be smaller than the gestational age. So this baby can be at a risk of even dying in the uterus. So we can easily decide that let this baby be delivered immediately using cesarean section method of delivery, so that we can save the baby. Then non-reassuring fetal status, if the baby is having um, a non-promising fetal heart, then we can also deliver this baby by cesarean section, because we want to save the baby. Then if it is under UFD is intrauterine fetal death. When the baby has died in the uterus, then we can also decide to deliver this baby by emergency cesarean section, so that we can actually reduce the bleeding, because if the mother continues bleeding with this IUFD, then it can also cause us more problems, and the mother can easily die, because IUFDs can also lead to a defect in the platelet levels and can cause us more danger or more hemorrhage to the mother, and we may not be able to save this mother. Since the baby has already died, then we can be able to actually decide that let us remove this baby very fast so that we can be able to save the mother. And then the other thing we need to note is that placenta previa is associated with morbidity, adherent placenta, so adequate preparation and expertise are a prerequisite. So consent the mother for possible hysterectomy. So you have to also prepare these mothers. Sometimes when they come, they don't expect some of these outcomes. So when they come to you and you have realized that this mother has this kind of condition, and you know that the outcome may not be a good one, then also counsel them for the possible outcomes that can come, and they should not be a surprise to their mother. For example, hysterectomy, that is not good for every woman. So you need to counsel them and you need to let them know that this can easily happen, so that when it happens, they are able to actually handle those kind of situations. And then
So,
of placenta previa, and I think we had moved very far. We had already talked about the different types of placenta previa. We had already talked about the risk factors, differential diagnosis, signs and symptoms, the possible investigations. We had done the management, and we are handling the slide that was talking about mild bleeding, how you're managing mild bleeding, and we're almost ending the presentation on mild bleeding, how you manage the mild bleeding. So I think power went off when we're trying to explain about the minor placenta previa like type 1 and 2A, where we can induce labor if no contraindications to vaginal delivery, that is type 1 and 2A. And then we said type 1 and type 2A, the mother can easily be induced because the type 2A, the placenta is located at the upper part, that is the anterior part of the uterus, and the baby cannot damage it during the time of delivery. Then the type 2B, we cannot do vaginal delivery because that one is at the posterior part of the uterus, down at the lower segment, and when the baby is being delivered, it can interfere with it and cause bleeding. So type 2A is at the anterior location, and then the type 2B is at the posterior part of the lower segment, which will not be possible for for a delivery. So we deliver that one by cesarean section. So indications for immediate delivery by C-section is where we were, and I said active bleeding plus hemorrhagic shock is where we can do immediate delivery by C-section. Gestational age, when it is more than or equal to 37 weeks with mild bleeding, we also do emergency cesarean section or immediate delivery by cesarean section. Then evidence of IUGR. I said IUGR is intrauterine growth restriction. The babies may not be growing well because they are deprived of nutrients and they end up being small for death. So this one can also put the baby at risk. So we can do immediate delivery by C-section if there is bleeding. Then non-reassuring fetal heart. When the mother has bled too much, we also realize that there will be little provision of oxygen nutrients to the baby, and this baby can easily have a deteriorating fetal heart, which we call fetal distress. And with that, we end up also deciding that this mother should be delivered by C-section so that we can be able to save both the baby and the mother. Then IUFD is intrauterine fetal death. These babies may die inside when the mother overbleeds and this baby is deprived of oxygen. This baby can easily die in the uterus and we end up losing it. So we can also decide to deliver if it is IUFD, especially during the time when the mother is overbleeding, and also if the placenta has totally covered the cervix. Even if it dilates, the baby cannot pass through. So the mother can be delivered by a cesarean section. Then I said we have to note this, that placenta previa is associated with morbidity, adherent placenta. So adequate preparation and expertise are a prerequisite, and we need to consent the mother for possible hysterectomy. So in relation to adherent placenta, the mother may end up with a possible hysterectomy because the placenta cannot be delivered. So the mother may lose her uterus, and we need to prepare her for those possible outcomes. Then what are the measures that should be taken in placenta previa cases? We said there should be frequent vital sign monitoring, and when you monitor these vital signs, you shall be able to identify deteriorating blood pressures and also accelerating pulse, so that we can manage this mother to prevent her from getting into shock. Then speculum examination on the third day to exclude incidental hemorrhage. If you've admitted this mother and she's not bleeding, on the third day, on admission, when she's within the hospital, you should not do digital vaginal exam, but you should do speculum examination to view whether the cervix is open and she's bleeding, so that you can intervene. Then scanning at 34 weeks to assess progress and confirm the diagnosis. This mother, sometimes maybe they have done the scan early in the early pregnancies, early weeks of gestation. So at around 34 weeks and 36, then you should also repeat the scan so that you can be able to confirm that really this is placenta previa as a diagnosis. Then patient retention in the hospital until the 37th week for examination under anesthesia and readiness for a cesarean section in case of severe bleeding. You should retain this mother in the hospital until she is 37 weeks so that you can be able to examine her. And when examining her, it should be under anesthesia, examination under anesthesia, so that she doesn't feel that pain. And also the mother should be prepared ready for cesarean section in case she has severe bleeding. So delivery options in placenta previa. So in type 1, having mentioned before, so I'm trying to explain this in these slides. Type 1 and 2 with an anterior placenta. Anterior meaning the placenta is at the upper part of the lower segment. You should rupture the membranes and spontaneous delivery may be considered, looking at the Bishop's score of 8 and above, but below 6 is unfavorable for induction. So if you're going also to induce labor at around this time, when the mother is having placenta previa and is either type 1 or 2 anterior, then you should also look at the Bishop's score. If it is below 8, then you should not do an induction of labor because she may not successfully deliver vaginally. Then labor induction with oxytocin drug can be done in case the Bishop's score is 8 and above. Then in type 2 with a posterior situated placenta, and type 3 and 4 cesarean section is performed. So type 2 posterior is when the placenta is at the lower part of the uterus, the lower part of the segment. Posterior, you know what posterior is, anterior. So anterior and posterior. So anterior, you can easily do vaginal examination. Then posterior, when it is below, then you should not, or you should avoid a vaginal examination. That is now posterior type 2, and then type 3 and 4. Those ones are basically for cesarean section. What could be the complications? In every emergency obstetric condition, we should expect complications. So there can be postpartum hemorrhage. When these mothers bleed before delivery, you should also expect bleeding after delivery. Then fetal hypoxia. Fetal hypoxia, we talked about the babies sometimes having unstable state inside the uterus and can be due to severe bleeding, and this can cause fetal hypoxia. And when the babies get fetal hypoxia, they end up actually depriving the brain with blood, oxygen, and then they end up with the severe complications after birth. Then there is also peperiosepsis. When these mothers lose blood, they end up with peperiosepsis, because when there is little blood, there will be also little supply of nutrients to different areas to activate the formation of antibodies that can help fight the infection, and this can end up with peperiosepsis. So peperiosepsis is also common in mothers who have had placenta previa because of the severe bleeding that they get, and this can give us more issues and complicates the healing of these mothers. And anemia is one of the major complications, and is the first occurrence of a complication in these mothers. So the first thing which happens when a mother bleeds is anemia, and when anemia sets in, then the mother will have the low BPs, as we mentioned. They have high pulse, trying to compensate, increase the respiratory rate, and that one will end up with hemorrhagic shock. So anemia is one of the complications, and they may heal, and after healing you still see these mothers are still anemic, and that's when we have to add them more of the hematinics so that they can be able to boost their immune system. And then maternal and fetal death can also occur, especially when anemia sets in and nothing is done. Then these mothers can easily die, plus also their babies. Now, we are going to look at the second condition that is major in antepartum hemorrhage, and this is abruptio placenta. So abruptio placentae moves hand in hand with placenta previa. If you don't get placenta previa in APH, then you suspect it's abruptio placenta. So abruptio placenta, abruptio is basically bleeding resulting from the premature separation of a normally situated placenta occurring after 26 weeks of gestation, or it refers to bleeding into the genital tract after 26 weeks of gestation and before delivery in a normally situated placenta at the fundus. So, as I explained about placenta previa, we said the placenta is located at the lower segment. But for the case of abruptio placenta, the placenta is located at the upper segment of the uterus, and that is the fundus. It is located normally, but the issue is it is separates before the baby is born. And when you look at the gestation age, as we say 26 weeks of gestation, this is the age whereby we feel these babies can survive if given all conditions that are necessary for managing a preterm. These babies can survive like any other child or any other baby or newborn. But if it is below 26 weeks, then that one will be called an abortion, and we don't expect them to survive despite of the services that can be provided or the care that can be provided. Usually before this new obstetric guideline, we used to take 28 weeks of gestation as in Uganda, but now due to the improved services to the neonatal care units that we have in our country in Uganda, actually the new guideline is now talking about 26 weeks, and I believe it's everywhere in the world now. But in the Western countries, they are considering 24 weeks. They say those babies can survive because they have more of technology services than we have. So associated conditions include hypertensive conditions, high parity, trauma, polyhydramnios, high fever, and external factors like sudden shock. So this could be the contributing or the predisposing factors to abruptio placenta. Types of abruptio placenta. As we talked about the types of placenta previa, we are also going to talk about the types of abruptio placenta. So when you look at the types of placenta previa, they can also be called grades. The grading of placenta previa can be grade 1, grade 2, grade 3, and grade 4. But here we are talking about abruptio placenta. So here there are basically three clinical presentations of abruptio placenta. So when they talk about the clinical presentations, we are looking at how this bleeding presents, and that is how we are able to identify the type of abruptio placentae. So one of them is the mixed type, and the mixed type is telling us that bleeding is both revealed and concealed. So you can see that the mother is bleeding, but at the same time you see there is some blood that is being concealed. There's some fluid in the abdomen, meaning that the bleeding is also concealed inside despite what you're seeing vaginally. So that one is called mixed abruptio placentae. Then you have concealed. Concealed, the mother is bleeding, but you don't see the blood, but you only see or you realize, or when you examine the abdomen, that there is some kind of fluid. The mother is feeling the pain and there is no visible bleeding. So when you examine this mother, you may realize that she's even pale, the BPs are very low, and there is increased pulse, and this can give you an indication that there is something happening inside the abdomen. So this is concealed, kind of abruptio placentae. Then revealed, that one, the revealed, revealing means showing out or showing off. So when this blood is seen vaginally, freely visible from the vagina, that one is called revealed abruptio placenta. You see the mother is actually bleeding, losing the blood. So what are the causes and predisposing factors placenta previa? Though we mentioned the definition, but we can still repeat them. They say previous history of abruptio placenta can also repeat itself. Direct trauma to the abdomen, that is by accidents. Hypertensive disorders of pregnancy can cause abruptio. Then polyhydramnios can also cause abruptio, and external cephalic version. External cephalic version is when the baby is being turned. In most cases, we used to see this with our traditional birth attendants. When the baby is a breech, they try to turn it to lie the normal way. When it is a transverse, they also try to make it turn to lie the normal way. But in that process of trying to turn this baby, they can easily detach the placenta and cause bleeding and separation. Then short cord and choriamnitis. The short cord can also affect as the baby is trying to descend. The placenta can easily start detaching. Then choriamnitis is the inflammation of the chorion and the amnion due to infections and can easily start separating. Uncontrolled artificial rupture of membranes can also be one. When you rupture the membranes, especially in polyhydramnios, and there is that sudden flow of the blood of the amniotic fluid, it can cause force to separate the placenta and causes placenta abruptio. And then folate deficiency, smoking, and external cephalic version. Having mentioned it from the previous slide, I think this was a repeated point. Then what are the differential diagnoses of abruptio placenta? There are differential diagnoses that can be mistaken as placenta abruptio. We talk about placenta previa, uterine rupture, vasa previa, trauma to the abdomen, degenerating fibroids, and then severe cystitis. This can be mistaken as abruptio placenta, and yet it may not be abruptio placenta, but they can also present almost in a related way to abruptio placenta. Then polynephritis, ovarian cyst, torsion, bleeding ectropion, and then cervical polyps or malignancies can cause bleeding, and when you don't examine this and do the necessary investigations, it can be mistaken as abruptio placenta. Signs and symptoms of abruptio placenta: revealed type, vaginal bleeding. Revealed meaning the blood is seen. So if the blood is seen, that is, there is profused bleeding. So the possible outcome is pain on the abdomen. There can be raised pulse, low blood pressures, and that can be also, there can be hypotension. It is supposed to be hypotension, that is the low blood pressures. Then concealed type. Concealed type is you realize the severe abdominal pain because the blood has been concealed. The mother can be in shock, and then there is no vaginal bleeding. You don't see any blood. There can be tenderness, and then board-like uterus. The mother feels a lot of guarding. When you try to touch, she's guarding. She's feeling a lot of pain, tenderness, and because of this concealed blood inside the uterus. Then absence of the fetal parts and heart sounds. Because of that blood, you may not even hear the fetal hearts of this baby. You may not even be able to touch the fetal parts because the blood that has been concealed inside the uterus will interfere with also the baby. When you're examining, even the mother may not allow you to palpate, and you may not be able to even listen because she does not feel any touch. She does not want someone to actually touch and try to press or compress or examine, palpate her abdomen because of the pain. Then combined types, the features of both the revealed and the concealed will be seen, and higher shock degree than visible blood loss. So you'll see the mother is really in shock, and there can be tenderness and rigidity of the uterus, and there will be constant pain. So there will be combined signs and symptoms, both of the concealed and the revealed. Then investigations are just like the same in placenta previa. We do blood grouping and cross matching. We do CBC to see the HB estimates and then the platelet levels. We also do the ultrasound to rule out what could be the issue. Is it placenta previa, placenta abruptio, and eventually may see it is placenta abruptio. And we should do bedside clotting time, prothrombin time, activated partial thromboplastin time should also be done, so that we can be able to rule out the complications or the defects in the clotting factors, so that we can be able to intervene what kind of blood products can be used in the transfusion or in the management of this mother. Because when the thrombin is very low, the platelets is actually very low, then this mother can easily bleed. So this can help us also in the management. What kind of delivery method can we use? What kind of type of delivery can we use so that we can reduce our complications? Then urinalysis, we do urinalysis basically for proteinuria to exclude preeclampsia, commonly which is associated with abruptio. So preeclampsia, eclampsia causes abruptio, but when you do urinalysis and you see that there is a lot of protein in urine, and then also the BPs are high, then you just know this is the cause of preeclampsia or eclampsia. So what is the management? Initiate continuous fetal heart rate monitoring. Make sure that you monitor the fetal heart so that you can avoid hypoxemic kind of effects that may lead to acidosis on this baby. Then secure intravenous access to help us improve on the circulatory system, because they need to have enough oxygen to the brain, vital organs, both the baby and the mother. So you need to put a large bore cannula, and considerably we need gauge 16, and when you put, you should put it 2, which will help you in the proper rehydration or resuscitation of this mother. So if the patient presents with signs of moderate or severe abruptio, such as moderate to heavy bleeding, and the mother is actually presenting with low BPs and pulse, high pulse, then you should know that this mother can easily get into shock, and you may not be able to get the blood vessels to access the intravenous lines. So you should make sure that you put this immediately this mother comes, before she gets into hypotension and shock. Then uterine hypertonicity and tenderness can be seen. So you need to make sure that you reduce this, you minimize it, so that you can avoid more complications. And then also coagulopathy or an abnormal fetal heart rate patterns should be identified so that intervention can be done immediately. Then notify the anesthetics team in moderate to severe abruption to help in the management of hemodynamic instability, bleeding disorders, and potential need for emergency C-section. So when you see all this, don't handle this mother alone. Call the other teams because it has to be multidisciplinary, and that's why they say it should be managed from a CMOC facility where there is a theater, there is a laboratory, there is a blood transfusion services, so that we can be able to handle this mother effectively. So inform the other team so that they can come in and you save the life of this mother. Then you have to maintain crystalloids to keep urine output to 30 ml per hour. So the normal output is supposed to be 30 ml per hour. Anything below that, you just know that this mother's kidneys are failing and she may end up with AKI, and that is acute kidney injury, which is very dangerous to our mothers, and they may need further management with dialysis, which most of our facilities may not be having. So maintain fluids and monitor the urine output. Then anticipate delivery within 24 hours to save the baby. Management of abruption continues. We say refer to a hospital if in a health center or dispensary, and that's why we talk about the smoke facilities. Start an intravenous drip and inform the hospital. If you're referring her to the hospital, put a line first before you send this mother, and make sure that you inform the hospital staff where you're sending this mother so that they can prepare adequately to receive this mother. Do blood grouping if you can do it, cross match if you can before the drip, so that you can set everything, put the blood, put the fluids, and let everything be maintained so that this mother can survive. And when you do this, you can be able to save the life of both of these two people. Admit the patient, call the doctor immediately if in the smoke facility, meaning that the mother has now come to the smoke facility where there is a theater, there is a doctor, there is an anesthetist, there are blood transfusion services. So when you admit this patient, inform the doctor immediately as soon as you get this mother. Then provide emotional support and physical care to the mother, and then the patient's relatives or the caretakers. They need to know the condition of this mother so that you can support them emotionally. They understand the situation. They can also understand the outcomes, the possible outcomes, and there they will be ready for any complication that may occur. But if you just keep quiet and things just work out the way that you think, then these patients, relatives or attendants will not be actually happy with you. So if you want to work together with them, then explain to them everything that you're trying to do. Let them know what is going on and let them participate if there is need for them to participate. Then relieve pain with IM morphine and then also or pethidine. So you have to relieve the pain where possible. Management of abruption placenta continues, and the other thing you should do is to treat for shock and ready of given fluids. So you treat for shock and prepare for cesarean section if there is severe bleeding. So manage this shock, manage the mother appropriately. If she has already gotten into shock, see how to handle her so that she will not die, and the baby can also be saved when you manage the mother. Frequent vital sign monitoring, the blood pressure, pulse, temperature should also be done consistently. Elevate the foot of the bed to prevent vena cava occlusion by the gravid uterus. And we know the vena cava is the one that is providing enough circulation to the brain, to the vital organs, and also for the fetus. So when there is a little supply, or when it is occluded, when it is compressed, then there will be deprived supply to the brain, the vital organs, and the baby, and you can easily lose the baby, and also the mother can get into shock because of this. And some of them can easily even die when they have little supply to the vital organs, both the baby and the mother. Maintain a urine output chart and test urine for protein. Having mentioned, the urine output should be maintained at 30 ml per hour, and that can be done basically by consistently maintaining the fluids and also transfusing this mother. Monitor blood for coagulation defects and clotting time. So we need to know this so that we can avoid PPH. We can also avoid some of the complications in the method of delivery if we take off a C-section per se. So this has to be monitored, this has to be known so that we should avoid other complications that can occur during our management. Then prepare for a reception and resuscitation of the baby. These babies always come with birth asphyxias, and then we really need to manage these babies because they are distressed. So when they are delivered, they are asphyxiated and they need vigorous resuscitation, which is skilled, so that we can be able to save them. And blood transfusion, if necessary, is key to saving both the baby and the mother. And if the mother is hemodynamically stable with cervical dilatation more than 7 centimeters or in second stage with no contraindications to vaginal delivery, do artificial rupture of membranes and allow the mother deliver vaginally with close monitoring. So you have to monitor this mother every 15 minutes so that you can be able to know the stability or the viability of the fetus and also the vital signs of the mother so that you can intervene before complications occur. Then do not perform vaginal examination in placenta previa. So in abruptio placenta, you can do vaginal examination, but in placenta previa, never do vaginal examination. And we talked about using a spatula for inspection of the cervix in placenta previa. So if the mother's condition deteriorates upper vaginal bleeding, hemodynamical state, so if the mother is bleeding, you can expect deterioration in her condition if nothing is done. So you should also do emergency cesarean section very fast so that this mother can be saved. Then perform a bedside ultrasound scan to determine the presence of the abruptio placenta. So abruptio placenta you can identify through abdominal ultrasound scan. So you can perform it from the bedside to rule out um, abruptio placenta and its state. Then if delivery is remote or more than 1 hour, remote meaning if it is going to take long, then proceed to deliver by emergency cesarean section. So if this mother cannot deliver vaginally within before 1 hour, then you should know that this mother may end up losing her life or the baby, so you can deliver her using a cesarean section, a method of delivery. Then prepare for neonatal resuscitation and refer the baby to the neonatal resuscitation section or to the neonatal unit when you have finished to deliver this baby. If there is no contraindication to vaginal delivery and the mother is hemodynamically stable, rupture the membranes, augment labor with oxytocin 2.5 to 5 international units in 500 ml of saline and allow the mother deliver vaginally. So if there is no contraindication and the mother is hemodynamically stable, those are the key things. The mother is hemodynamically stable and no contraindications, and you know that this mother can easily deliver vaginally, then you can go ahead and augment, meaning she is already in labor, but you're just going to increase either the contractions to fasten the delivery so that this mother can deliver. But the amount of oxytocin that you're going to use should also matter, and that is 2.5 to 5 international units in 5 ml of saline. And the drops should be considered. You start with 10, then you keep increasing depending on the response of the contractions to this oxytocin. So you don't just put it and you move, but you have to put it, monitor, regulate, and see whether it's causing any positive impact. Then you can be able to say that now I'm going to have a successful vaginal delivery with my mother. However, if the condition of the mother is deteriorating, proceed to deliver by cesarean section. So as I mentioned earlier on, the key things is the condition of the mother and then the hemodynamical stability of this mother should be considered. If there's deterioration in her condition, then you should not continue monitoring this mother to deliver vaginally, but do a cesarean section. Anticipate and prepare for PPH due to atony and Coverley kind of uterus. So what happens when the mother bleeds inside concealed? This blood goes and it settles in a particular side or a particular corner, a particular angle of the uterus, and it causes a softness on that part where it has actually settled. So even the contraction of the uterus around that area may not be possible, and that part can easily bleed, can easily give way because it is soft, and the uterus can continue bleeding and this mother can easily die. So anticipate and prepare for PPH due to atony and convolute kind of uterus. So this is very key and very important. Sometimes we end up only delivering the baby, and when the baby is delivered, we think that we have done our part and that is all, but we don't think ahead that this mother had this condition and can predispose her to this. What should we do? So you have to be prepared for this so that you can be able to support this mother completely and save the life of this mother. Conservative management for mild placental separation. Intrauterine scanning and continuous fetal monitoring should be done. If the mother and the baby are well and gestation is under 37 weeks, then discharge and weekly antenatal clinic visits. So you can do ultrasound scan and then also continue doing the fetal monitoring. But in case this mother is under 37 weeks, then you can make her go home but continue monitoring her antenatally at least weekly. She should come for antenatal visits so that you can see the well-being of both the baby and the mother. At 37 weeks, readmit for induction and if needed, do a cesarean section to deliver the baby. Clinical features of placenta previa versus abruptio placenta. These are the key conditions that cause antepartum hemorrhage. Having talked about placenta previa, having talked about abruptio placenta, we also have the clinical features that are key in both conditions, and that's how we are able to differentiate. We mentioned them in the presentation, but I decided to make this slide basically to help us understand and compare the kind of signs and symptoms that occur in each condition. So history of warning blood in placenta previa can occur. You can see some slight drop of blood and you start suspecting that is in placenta previa. Then less likely to be preceded by warning bleed. So when you look at this, the mother in abruptio placenta does not see anything like a drip of blood. A drop of blood is never there, but you only just see the mother is bleeding suddenly. Not like the placenta previa where she sees warning bleed, some slight thing, and then you can suspect. Then apparently costless. So it is not caused by anything. The bleeding just occurs. That's why we mentioned the mother can wake up from the bed and just see she's in a pool of blood. But in abruptio placenta, it may be associated with hypertension disorders, trauma. So when the mother tells you I have hypertension, the mother says I fell down, I got an accident, I hit my abdomen, I was either had domestic violence, then you can just know this is abruptio placenta. Then in placenta previa, you have shock and anemia, which corresponds to apparent blood loss. So the more the mother bleeds, the more she gets into shock, and you will know this is placenta previa. On the other side, shock and anemia may be out of proportion to apparent blood loss. You may not understand. The mother has lost even little blood. You're seeing a visible bleeding, but the mother is already in shock, meaning she can be having mixed or concealed kind of bleeding. Then our uterus has normal tone and is not tender, and there is no pain. But on the other side of our brush, there is increased uterine tone and tenderness, and also there is pain. Then when you look at on this other side of placenta previa, there's malpresentation and high presenting part, because the placenta has covered the lower segment, so it can cause malpresentation and a high presenting part. Then on the side of abruptio, there's normal presenting part because the lower segment is free and this baby can even engage. Then on the other side of placenta previa, I have the normal fetal heart rate and fetal assessment. When you do the the investigations, when you do any kind of assessment on the baby, when you monitor the fetal heart, you find they are all very normal. But on the side of abruptio placenta, more likely absent or abnormal, because the baby has been, the placenta has been detached, and the baby is not having enough supply of blood, and there it is lacking oxygen, so this baby can easily lose its fetal heart, and the fetal growth restriction can also occur. And in placenta previa, it is recurrent, it continues, it starts with a warning bleed, then after that it can increase until it becomes severe. But on the side of abruptio placenta, for it, it does not, there's none recurrent, it just comes and that is it. On the side of placenta previa, we have bright red blood, but on the abruptio, we can have dark red blood, and that's when you can be able, when you look at this side, you see the blood is very red, then you suspect this is placenta previa. When you look at on the other side, you see the blood is dark red, then you suspect abruptio placentae. Then in most cases, fetus is alive on placenta previa because it doesn't affect the baby. But when you look at abruptio placenta, in most cases the fetus is dead because the placenta has detached, so it has affected the life of this baby, so the baby can easily die. So it's not associated with PET. Placenta previa is not associated with preeclampsia or eclampsia. But when you look at abruptio placenta, it is associated, it's sometimes associated with placenta, preeclampsia or eclampsia. What are the complications? So we talked about the complications of placenta previa, and here we are also talking about the complications of abruptio placenta. So what are the complications of abruptio placenta? There is blood clotting failure. The blood may fail to clot. Then we have renal failure. We can have sepsis, just like in placenta previa. We can also have anemia, just like in placenta previa. We can also have maternal and fetal death in relation to the amount of blood loss. Then anterior pituitary gland necrosis may occur in severe bleeding due to insufficiency of supply to the brain. Then secondary infertility can occur if this mother loses her uterus due to convolute kind of uterus. This mother may end up with TAR or STAR, then she can end up with secondary infertility, which would have not been planned for. Intellectual disability, we talked about little supply or lack of oxygen to the brain and nutrients to the brain. Other vital organs can affect the intellectual abilities of this mother and even the baby. So it's very important that when these mothers are bleeding, try to look for all possible ways to secure that the brain remains alive, the brain does not lack oxygen, so that we maintain the intellectual abilities of these mothers and their babies. Then developmental delays in the baby services. These babies, actually, in most cases, when we deliver them, we need to really take them to the neonatal units where they get the CPAP. That's when they are actually sustained with the supply of oxygen to the brain. But when we delay to take them to those units, these babies end up with hypoxia. They end up with HIE, hypoxic encephalopathy, and they end up with such complications. And when they end up with such complications, these babies can end up with cerebral palsy. So it's not good for us to keep these babies with us in labor suite or in theater. So this hypoxic encephalopathy ischemia is very, very dangerous to the brains of these babies. So they are also in grades. They can say HIE1, HIE2, HIE3. For the HIE1, these ones are sometimes the damage to the brain is minimal, and HIE2, it can also be moderate. Then HIE3, the damage to the brain can be very, very severe, and they end up with cerebral palsy, where the baby cannot sit, the baby cannot stand, they take long to start walking, or even they may fail to sit for the rest of their lives. And this can affect the family, and can also cause more loss of resources to the family, because they keep trying to see that their baby is able to do other activities like any other baby, but the brain cannot coordinate those activities because it has already been damaged. Then preterm and premature deliveries can also occur, because if the mother is bleeding profusely, you cannot keep this mother. That because the baby is still with a low gestation age, let's try to keep her, and yet the mother is bleeding. No, we may end up doing a cesarean section if it is if the mother is bleeding profusely, hemodynamically unstable, and end up delivering these babies before time. And remember also, prematurity is one of the causes of premature, death of our babies, early neonatal death, and so forth. So we need to see that we reduce this if we are able to, and also have to see that we minimize the deliveries of prematures. If we are able to keep these mothers with conservative management so that they can push up the gestational age, let's try to do that. So this is the end of our lecture. It is the end of our presentation today. And I want to say thank you very much. And let's meet again next time. And this has been Maternal Newborn Nursing 2. And next time when we meet, we are going to continue from here. But we are also going to have a health assessment lesson 1. And that will be either tomorrow in the afternoon. I will communicate. So thank you very much, and see you, meet you again. Bye.